Welcome to our series, The Science of Brain Health, MS on Your Mind. Our webcast today is part 2 of this two-part series. Thank you for joining us. My name is Jackie, and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question or report a technical issue, click in the text box and type your text. When finished, click the Send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, you will be prompted to complete an evaluation. Your feedback will help us improve our future programs. We are joined today by our moderator, Rebecca King, Director of Education and Healthcare Relations with the Multiple Sclerosis Association of America, and our speaker, Dr. Augusto Miravalle, Associate Clinical Professor of Neurology at the University of Colorado School of Medicine. At this time, I would like to turn the microphone over to our moderator, Rebecca, for opening remarks.
Hi, thank you, and good evening. My name is Rebecca King, and I am the Northeast Director for Education and Healthcare Relations for the Multiple Sclerosis Association of America, or as we like to call it, MSAA. It's a lovely evening here in Washington, D.C., so I hope that wherever you are, whether it's in your living room or bedroom or maybe even outside on your porch, that you are having a nice evening as well. So last week, we had the opportunity to hear from Dr. Augusto Miravalle on the science of brain health, which is the first part of our two-part series, MS on Your Mind. Tonight's webinar is a continuation of that series titled Measuring Brain Health. And for those who missed last week's webinar, don't fret, it will be available shortly on MSAA's website, as well as the presentation from tonight. And one last item before I introduce our wonderful speaker, I would like to encourage all of you to complete a survey that will be available immediately following the last slide of the presentation. It's only 5 questions, I think, only 5. And we take our jobs very seriously at MSAA, and your feedback really helps us direct our programs and our resources. So with that, I would love to introduce all of you to Dr. Augusto Miravalle, who is currently a neurologist practicing in the Fort Collins area of Colorado, specializing in MS and other related neuroimmunological disorders of the brain and spinal cord. With over 2 decades of experience, Dr. Miravalle has won numerous awards and is passionate about shaping up-and-coming medical professionals. Honestly, I could probably spend a full hour just listing out all of his accomplishments, but he completed his residency at Loyola University in Chicago and a subsequent fellowship at Harvard in Cambridge, Massachusetts. So, without further ado, I will hand the presentation over to Dr. Miravalle.
Thank you, Rebecca, and again, thank you for MSAA for your efforts and for supporting this type of educational activities, particularly in topics so important as brain health. And just to recap for what we did last week we spoke a little bit about brain health, the science behind that, and how now we can speak to evidence in terms of how to measure brain health and how to understand how different interventions are going to impact our patients' brain health. And I think this topic is of importance and relevance because not only provides practical guidance to our patients on what to do in their lives in order to improve the function of the most important organ, which is the brain, but also allows to reframe the conversation in multiple sclerosis from a different angle. For decades, we've been talking about MS as a disease, and indeed it is a disease. but it is refreshing to be able to talk about MS from a health perspective, to be able to discuss with our patients how to be healthier, not only how to stop a disease from progressing, but also what can we do to allow you to be healthier. And that approach, that different angle that we can have in the conversation creates a different tone and provides patients for not only hope, but also a different perspective in how to empower themselves to take better control of their lives. So without further ado, let me refresh your memory in terms of what is multiple sclerosis, and I'm sure you're all familiar with it. But this slide presents the perspective of the pathophysiology of multiple sclerosis, meaning what is happening inside someone's brain when someone has multiple sclerosis. So as you can see in this slide, in the first phase of the disease, and that's usually anywhere between time of onset of symptoms to anywhere between 15 to 20 years from diagnosis, there is a very active phase of inflammation, and that is inflammation that is triggered by an unknown antigen. We still don't know what causes or triggers MS. But once that inflammation, that inflammatory immune system gets activated, it's going to be trained to go after self-antigens. In this case, pretty likely going to be antigens present inside the brain, likely in the myelin compartment. And as you can see in the graph, the younger the patient is, the more active that inflammation becomes. The good news is that the brain is one of those organs that is able to regenerate and repair. And that is another concept that changed in the last decade, in which when I did med school, I learned that the brain is not able to repair. However, now we know that there are inherited repair mechanisms in the brain that allows to restore function from a natural standpoint. And knowing those mechanisms is also allowing for the development of medications that perhaps will take advantage of that and help us restore function in the future in multiple sclerosis. But we don't have medications yet approved that are known to remyelinate or repair. However, as you can see here, the earlier or the younger the patient is, the more likely that it's going to be able to repair after there is some sort of damage to the brain. And the older the individual gets, the less likely that repair will occur. And then the second phase of the disease is something that we call degeneration or progression. And that has to do with the slow progressive phase of MS, that once that progression reaches a clinical threshold, that means that when patients actually notice symptoms from that progression, that's when we usually clinically label someone going from a relapsing remitting multiple sclerosis to a secondary progressive multiple sclerosis. And symptoms from progression include anywhere from fatigue to cognitive decline to decreased walking or ambulation. And they are different. Those symptoms are different to the symptoms that patients have when they have relapses. So when these two lines crosses, that's usually when we see that the inflammation or the amount of inflammation continues to decrease and the amount of progression or degeneration continues to increase. So on the bottom of the slide, you see three pictures, and that's representing actual brain cells and what is happening inside the brain. In the left far corner, you see a blood vessel surrounded by these blue dots. Those are immune cells getting inside the brain. In the middle, you see a white patch. That's an area of demyelination or loss of myelin. And on the right-hand side, on the chart that is labeled as C, you can see a black line that has two bulbs. Well, that's a brain cell, an axon, that is being demyelinated in the middle and is about to break. And whenever there is axonal loss in a multiple sclerosis, we worry because that's one of the predictors of disability. That means that the inflammation reached a deeper level than just simply causing loss of myelin, and is affecting the nerve cells themselves. So something we also spoke last week is the concept of brain reserve. And we talked about that brain reserve is this functional compartment of the brain that allows to compensate for loss of function or to also compensate for aging, which is something that we all go through every day. So as we age, the ability to compensate for the brain also decreases because we are using more of that brain reserve over time. Patients with multiple sclerosis are known to use more brain reserve early on to compensate for the presence of those lesions. And that's why you see in this slide that the neurological reserve declines as patients ages over time, and also declines as patients accumulate lesions on the brain, which are depicted as these orange arrows in the cartoon, and also as patients have relapses. So one practical way to prevent that further decline of brain reserve is to prevent relapses and to prevent lesions. And we spoke last week about how to do that efficiently with medications. And that's one of the first principles on brain health, which is we know that there is inflammation in MS, so we need to stop inflammation with medications. That's the number one step. Of course, that's not the only step we need to make in multiple sclerosis. We always advocate, particularly more recently, to a comprehensive multidisciplinary approach. It's not just a medication. Usually is a combination of physical activity, exercise, nutrition, everything we do to improve brain health. But we need to stop inflammation. Without that, it's very difficult to accomplish brain health. So this model is also known as a topographical model of MS, is trying to depict in a visual way this concept of brain reserve. And the author, Stephen Krieger, decided to make an analogy of the brain reserve to the water in a swimming pool. And you can see on the graph on the picture A that in that water, in the swimming pool, there are three different sections: a shallow end, a deep end, and a middle end. And these three different sections will have three different levels of water. And these three sections represent three different anatomical regions of the central nervous system, anywhere from the spinal cord and the optic nerve in the shallow end to the cerebral hemispheres in the deep end. And what that is trying to tell you is that different areas of the central nervous system will have different amount of brain reserve. And that explains why sometimes lesions cause symptoms. For example, lesions on the spinal cord, on the optic nerve, because they have less brain reserve, and why certain lesions don't cause symptoms, like the example of lesions in the deep white matter on the cerebral hemispheres, because those regions in the brain have more brain reserve, a more brain that is able to compensate for the loss of myelin in those areas. So this model already explains one common question that patients ask, which is, wait a minute, why do I have 20 lesions and I only had 2 relapses? And that is explained by this process, the fact that certain areas of the brain will have more ability to compensate. The other question that this model explains is the following, which is, why do I get worse as I age? And then I do an MRI and I have the same number of lesions. Why is that happening to me? And I'm sure many patients listening to this presentation perhaps relate to that situation, particularly after your 40s or 50s. Well, as you can see in the model, the water level is going to cover these bumps that are representing the lesions. And when you go to the picture B on the graph, you can see that there's tiny bumps in the deep side of the pool that are being covered by water level. And what that is representing is lesions in the brain that have been, in a sense, compensated by brain reserve. But as someone ages over time, the amount of brain reserve decreases. In this model will be equivalent to the amount of water in the pool will go down. And as that process occurs, it's going to unfold lesions that were previously compensated. And that's why all of a sudden someone with MS for 20, 30 years with the same number of lesions will start to experience new symptoms or worsening. Because in a sense, there is this loss of brain reserve that has been compensating for years the presence of those lesions. So this concept is very important to understand because that's going to give you some sort of idea of how to start the process of accomplishing brain health, which is some patients actually, after I explain this to them, they say, well, I need more water in my pool. And that's exactly the type of reaction you should have after listening to this explanation. That's absolutely right. You need to bring more water to your pool. And the question is, how can you do that? Well, the first answer is we need to stop inflammation. As I mentioned before, if you keep adding lesions to the brain, it's going to be very difficult to accomplish brain health. The second one is has to do with bringing activities to your life that will allow you to make the most of that brain connections that you have, the 10,000 brain connections you have in your brain that are allowing you to actually do the things you want to do. How do we measure that brain reserve, and how can we know that the interventions that we are recommending are actually impacting your brain reserve? One tool we have is an MRI. So I'm sure many of you, if not all, have had MRIs in the past. And MRIs is a machine that is allowing us to understand not only the anatomy, but most recent MRIs called the functional MRIs allow us to understand the function of the brain. So this is a cartoon that shows you the machine, which you're familiar with it. It's been designed for many years, over 40 years. We know that the MRIs exist, and we continue to improve the quality of the scans. There are different strengths of MRIs, and we measure those with a unit called Tesla. So the 3 Tesla MRIs are the ones that are commercially available, that are the highest field strength. But we do have 7 Tesla and even higher that are available for research. And a common question that I get asked is, do I get exposed to radiation with MRIs? Well, the answer is no. MRIs, as the name implies, magnetic resonance imaging, it's exposing your brain and your tissues to a magnetic field. And what that's going to do, it's going to align all the protons, the water molecules in your tissues in a way that will then measure the energy that is released from those protons in order to acquire resting state again. And that energy is transformed into a signal in the brain, and that signal allows us to understand the amount of water and fat and different tissues that you have in different organs. So we usually use MRIs in MS for multiple reasons. We use that to not only diagnose someone with multiple sclerosis and actually rule out alternative diagnosis, but also to determine the evolution of existing lesions and the occurrence of new lesions. We also use MRIs to detect subclinical activity. And with that I mean, sometimes patients feel stable and we do a physical exam and they're completely unchanged, but we do an MRI and there are new lesions happening. And by now you should be able to explain why. Well, those new lesions are actually affecting areas with high brain reserve, and that's why patients don't have symptoms from that. But it's important to detect those lesions early on, because that usually means that the medications or interventions we are using are suboptimal in order to control the disease. We also use MRIs to evaluate response to a given treatment. So this is what is known as the McDonald criteria for the diagnosis of MS, and we follow that in any MS center in order to have more certainty and specificity on the diagnosis of MS, and we use these 2 categories called dissemination in time and dissemination in space. So, and this is an example of how it's reached, and by now you should be familiar with this, and if you're not, this is available through these and other resources, which is being able to diagnose multiple sclerosis with some degree of certainty. And we need to have a combination of different factors. Sometimes patients are diagnosed with one clinical event, sometimes they are diagnosed with multiple clinical events, and that depends on how the MRI looks. And this is a slide that show you something that perhaps you've seen before, which is how the lesions look on an MRI, and they usually look these ovoid-shaped, white-looking lesions we call hyperintensities. That if you pay close attention, some of those lesions will have this dark line in the middle, and that dark line, I'm going to try to point to one here, is right there. That dark line in the middle of the lesion is what we call the central vein sign. That means that there is a small little vein in the middle of the lesion that it's where the immune cells actually reach the brain and start causing demyelination. Lesions can also occur on the spinal cord, and I'm going to show you some lesions here that actually also serve for the diagnosis of multiple sclerosis. And this is just a summary of whether these lesions could be in the middle of the brain, like in this case. Let me just put the arrow in the right place. We call this the corpus callosum, and that's an area of the brain that is very commonly affected with multiple sclerosis lesions. We spoke about music therapy last week, and we discussed the fact that trained musicians have thicker corpus callosum. That's one of the areas of research that is of most interest now, to try to see if we can actually improve the brain health in that area by musical training in patients with MS. And then, of course, we have what I mentioned before, the presence of the central vein sign, which is these dark lines in the middle of the lesion. When you have two or more of those lines, it usually increases sensitivity and specificity to 70 and 90% on the diagnosis of multiple sclerosis, which is pretty high. So this gives you some sort of basic understanding of MRIs, and the reason I decided to include these slides is because I will talk about MRIs quite a lot. So I want to make sure everyone has some sort of basic understanding on how MRIs work and what type of things we'll look into an MRI. So let's get back to principles assessing brain health. So when we look at advanced neuroimaging, we do see that there are changes on the brains on MS patients that go above and beyond lesions, and they go above and beyond relapses. And this is very important to understand, because when we look at lesions, we're only looking at the tip of the iceberg. We're looking at the focal area of demyelination that we are able to see with the MRIs, but that's not the extent of the damage that is happening in multiple sclerosis. And that functional reorganization is present as early as the first clinical event. And that is something that, again, is important to understand, that very early in the process, there is a lot of damage that is happening. And as a matter of fact, as I mentioned before with a slide showing inflammation, the amount of inflammation is maximal early on. And that's why contemporary ways to treat multiple sclerosis advocate for the use of highly effective therapies as early as possible, because that's the window of opportunity that we have to truly affect the course of inflammation. And the other concept that is also important to remember is that this functional reorganization in the brain, some call that neuronal plasticity, is something that it's important to understand, because we can take advantage of that in order to improve function. So neuronal plasticity means that the ability of the brain to rewire areas to be able to compensate for loss of functions in remote areas. And we'll look at some pictures in future slide that is showing you how the brain can rewire itself to try to compensate for loss of functions. Let's go back to inflammation. Inflammation can influence synaptic transmission, meaning the ability of the nerve cells to communicate with each other. And that impairment is going to affect the ability to compensate for loss of function. That's the principle I was mentioning before. It's very difficult to restore function if there is still active inflammation occurring in the brain. Inflammation can also damage connections. And that's why that's going to hinder the ability to create plasticity and effectively drive recovery. And that is, again, it's a point that I want to emphasize, which has to do sometimes with patients having second thoughts on the use of anti-inflammatory therapies for multiple sclerosis on the basis of feeling stable. And that's something that I always celebrate, the fact that they feel stable. But at the same time, I try to emphasize the importance of being on any disease-modifying therapy because we are affecting inflammation, and that step is critical in order to accomplish brain health in the future. And last but not least, inflammation can also alter the neurovascular coupling. And that's something that actually we are starting to understand now, which is this relationship between the nerve endings and the nerve cells in the brain and the blood vessels in the brain, and how that brain flow is going to increase the oxygen levels and is going to decrease the toxins present in the brain. So if you have inflammation, the whole system that is going to be able to clean up the toxins in the brain is also going to be altered. And this is one of the examples I was mentioning before. By using functional MRI, we can actually measure that plasticity of the brain. So on the top row, you can see a healthy control individual. So the top line of brains is an individual that is being placed in a functional MRI, and he was asked to do a finger tapping using the right index finger. So all he was doing is tapping with his right index finger in the table. And you can see the amount of area that is being activated. Here you can see the red and the orange and the yellow areas. Those are areas of the brain that has been activated by just simply doing finger tapping. On the bottom row, you can see a patient with multiple sclerosis of the same gender and the same age doing the exact same function, in this case, finger tapping again. And you can see that the amount of brain that is being utilized to do that function is significantly higher. And one of the things you can conclude now by looking at this is by doing the same function, MS patients are using more brain reserve, are actually exposing that system to a higher energy demand. And the other conclusion you can make is why MS patients end up having fatigue. Well, if you're constantly using more brain in order to accomplish the same type of functions that you want to do, at some point the brain is going to become exhausted. And that's when you exhaust your brain reserve, the ability to compensate, and that's why your brain shuts down. So one of the ways to understand fatigue, particularly that mental fatigue that happens in MS, is looking at these type of examples with functional MRI, in which patients are constantly using more brain in order to accomplish the same type of function. So this is an example of motor tasks, finger tapping, for example, and how we can measure cortical activation. So as I mentioned in the previous slide, MS patients have greater cortical activation, meaning they're using more brain than healthy subjects in order to accomplish motor functions in both cerebral hemispheres, even in the contralateral part of the brain, in order to compensate for the loss of myelin. So in order to understand how that change occurs over time, when you look at different MS phenotypes, meaning relapsing and remitting in multiple sclerosis, secondary progressive MS, and primary progressive MS, it seems like the longer someone had MS, the duration of the disease is longer, the more extended activation happens in the brain. And that, again, has to do with the amount of inflammation that someone accumulated over time. And of course, as you can imagine, the increased cortical activation was found to correlate with severity of tissue damage, or in this case, lesions. So the more inflammation you have, the higher the number of lesions, also is going to correlate with a higher amount of cortical activation in order to perform the same motor task. But it's not only related to motor tasks that we look at higher amount of cortical activation, also has to do with cognitive tasks, meaning what happens when you're looking at intellectual cognitive activities in multiple sclerosis. Well, the same principle occurs when patients are trying to concentrate or remember or pay attention. They're constantly using more brain with higher cortical activation than individuals of the same age without multiple sclerosis. And this was a similar study looking at a functional MRI. that look at controls in the top row and baseline multiple sclerosis patient. And you can see that when these individuals were doing the similar cognitive activity, MS patients were having a higher amount of cortical activation. And what I'm going to show you next is one of the first studies that actually showed some benefit on the amount of cortical activation that was the result of a combination of anti-inflammatory therapies plus cognitive behavioral therapies, meaning the more and the better you use your brain, the more efficient that system becomes. So that same patient that was studied at baseline with multiple sclerosis was then studied after 1 and 2 sessions of cognitive behavioral therapy, meaning training the brain to think faster and to mitigate fatigue. And that patient also was placed on a disease-modifying therapy for multiple sclerosis. And you can see that after the second session, that MS patient, the amount of cortical activation was similar to a healthy control and significantly lower than the baseline amount of cortical activation that the same patient had before cognitive training and before starting disease-modifying therapies. So this was a study that for the first time showed a positive impact in the amount of cortical activation by the combination of highly effective disease-modifying therapies plus the use of cognitive behavioral therapies. So these type of studies are giving us the evidence that we can rewire your brain. You can train your brain to become more efficient if you do the right things in multiple sclerosis. What about other brain disorders? Is this a phenomenon on cortical plasticity and remyelination unique to multiple sclerosis? And the answer is no. And we've seen that with perhaps the most severe form of loss of brain health, which is a stroke. So when someone has a stroke, they're actually losing brain parenchyma. They're losing a large amount of brain. And in this case, you can see that this individual lost a significant amount of brain, in this case, almost the entire left hemisphere. You can see this black area in the brain. So when that patient was doing physical activity after the stroke, the contralateral side of the brain, the right side, was picking up the function for that left side that was inexistent. You can see at baseline that the amount of activation on the right side was maximal. Well, after training and physical therapy, you can see that the same patient had the same amount of stroke, but now was using a small area on the left side, which was the right side to use. So you can see that even in the context of a stroke, you can help the brain to rewire itself and become more efficient. So let's go back to multiple sclerosis now. And we mentioned before that there is this declining brain health as a consequence of age, as well as a consequence of disease progression. We also talked about the difference between relapses, which are these acute events of demyelination that is usually defined as symptoms or signs that last more than 24 hours that are associated with deficits or loss of function in the absence of something else that could explain these symptoms, usually infections. In addition to relapses, patients can have progression, and that usually is manifested clinically by a decline of function of more than 6 months, and usually comes with fatigue and cognitive decline in the absence of deconditioning, meaning in the absence of someone feeling worse just because they are not as active physically. We are currently going through a difficult time with the pandemic, and most patients are in-house, indoors, and they are not as active as they used to be. So it's very difficult now if someone feels worse to know, is this true progression, or is this because you've been not as active, you've been not exercising, or as socially engaged as before. So this is actually a perfect time to understand the difference between deconditioning and clinical progression. On the right-hand side, you can see the distribution of symptoms in different types of multiple sclerosis. Usually those symptoms are anywhere from sensory symptoms, tingling, numbness, optic neuritis, difficulty walking, weakness, and so on and so forth. So in summary, I want to mention that basically inflammation is something that we need to avoid, even in the absence of clinical signs of inflammatory relapses. Inflammation is happening in the brain of someone with multiple sclerosis. Inflammation is measured usually by the presence of lesions or clinical relapses, but there is also inflammation outside the lesions, and there is certainly disease activity that goes in between relapses that we need to be aware of. MRI is a critical tool that we use in this case to look at not only the role of our interventions in understanding how that impacts someone's disease activity, but also in starting to assess brain health by looking at the reorganization of these brain pathways, by looking at cortical activation as a surrogate marker for neuronal plasticity, and see how different interventions, physical activity, training, exercise can affect the reorganization of the brain in a much healthier way. But that's not only limited to physical activity and motor tasks. We also know that cortical activation during cognitive tasks is affected with multiple sclerosis, and how training can actually improve that to the point that becomes similar to healthy controls. So this summarizes and is the last slide for today's presentation. Just to do a recap of the two sessions that we had last week, and today we talked about MS as a disease itself. We talked about the importance and the role of nutrition and diet last week. We discussed that, even though there are different diets that has been, in a sense, studied in multiple sclerosis with different names, it's hard to truly have a lot of evidence to recommend a single diet. Perhaps the Mediterranean diet is the one that has the strongest evidence. We talked about the role of exercise. We talked about the role of disease-modifying therapies in multiple sclerosis. We also talked about music therapy last week. And today we talked a little bit about the role of cognitive behavioral therapy and cognitive training, usually done by an occupational therapist and a neuropsychologist to try to make the brain more efficient. And there were some questions last week about the role of certain vitamins, for example, vitamin D and biotin in multiple sclerosis, and we reviewed some of that data. So with that, I see that there are a lot of questions, so I want to make sure that we have time to answer them all. I want to conclude by, again, saying thank you to MSAA for allowing me to participate in this case series. I mentioned last week, and I see that there are some questions coming, that we do have, my wife and I, we started a nonprofit organization to be able to offer patients with neurological disorders, not just multiple sclerosis, brain health training, and we currently offer a 6-week training that is absolutely free of charge. And in those 6 weeks, we cover in pretty much at length all the principles that we discussed these last 2 weeks. You can find more information in our website, that is www.brainhealthcr.org. That's again, brainhealthcr altogether in lowcaps.org. And then we'll be happy to share with you information about the 6-week program. It's now being offered online via Zoom meetings. And that's one of the things that actually we had to move on to that platform due to COVID-19. And so far it's been very successful. And of course, we work in collaboration with MSAA to be able to offer these and other programs. So with that, I'm going to conclude this and open the discussion to answer any questions.
Thank you, Dr. Miravalle. That was all really great information. Certainly all new, almost entirely all new information to myself. So to kick off the questions, the first question we have is from Anthony. And he's asking if the presence of one new or increasing lesions on the brain, even if it's just really slight in size, can it result in significant cognitive issues, or is the size and volume of brain lesions directly related to cognitive problems?
Yeah, that's a great question. And that's a question that is being asked multiple times by researchers to try to understand how many lesions are too many? When do we, as clinicians, need to change disease-modifying therapies based on the number of lesions? And unfortunately, there hasn't seemed to be a good answer that fits everyone. When you compare all patients together, it seems like 2 or more lesions usually is a number that justifies changes in disease-modifying therapies without any doubts. So if someone has 2 or more lesions, there is no doubt that these individuals have to at least have a conversation about changing disease-modifying therapies. The argument and controversy becomes when there are less than that. Is 1 lesion enough to change therapies? Well, that truly depends on what therapy you are on. If you are using some of the lower efficacy therapies, the injectable therapies, for example, and some of the oral therapies, I will argue that perhaps, yes, you need to move on to something better because you do have better options. But if you are already on the highest efficacy therapy available and you're having 1 new lesion, but perhaps before this therapy you were having 10 new lesions every year, well, that perhaps changes the equation to the point that, well, perhaps there is nothing else we can do, and perhaps that 1 new lesion is not as meaningful as that 1 new lesion in the other patient I explained before. So in less than 2 lesions, usually it's when we decide to do on a case-to-case basis. Then the conversation about a lesion and cognitive decline is a challenging one because usually lesions don't necessarily correlate with cognitive decline. Cognitive decline usually correlates better with atrophy. And atrophy means loss of brain parenchyma or loss of brain volume. And when you look at a correlation between lesions and cognitive decline, it's not as strong as a correlation between brain atrophy and cognitive decline.
Great. So the next question we have is from Kimberly. She states that the last few years I've had trouble making decisions that used to be so simple. And I try to just get through it, but I second guess myself all of the time, back and forth. And I've had MS for a long time, and I have many brain lesions and some parenchymal volume loss. I'm sorry if I butchered that. I use meditation and a computer game to help keep my mind sharp and to help it heal. But do you have any other suggestions?
Yeah, so, and Kimberly's story is not that different to many other patients, right? So is this situation in which, you've been using perhaps multiple medications, and despite that, you still have lesions, you have parenchymal volume loss or brain volume loss. And what can we do to prevent not only further damage, but also to improve function? And that is a perfect example of why we are talking about this today. It's a combination of, again, highly effective therapies. I will recommend Kim to discuss with her neurologist on what other therapies are available. If you already went through many medications and you failed many, maybe there is something we can do in the research area in trying to look at new therapies that are being investigated currently. But also, don't stop with a neurologist, right? So the care of MS patients require a multidisciplinary approach. You have to have a physical therapist that you need to work with. I recommend at least once a year see a physical therapist, and don't wait until you have a relapse to see a physical therapist. Actually, if you feel that you're in your best state, that's when you need to see a physical therapist, not to restore function, but actually what can you do now to improve endurance so you can improve function in the future. You also need to consider seeing an occupational therapist to see if there is anything you can do to optimize cognitive function in the brain. Occupational therapists are the physical therapists of the brain, right? So they will help you understand how to measure and mitigate fatigue. They will look at your sleep schedule, for example. They will look at your work schedule and how to save energy on one end and how to use energy on the other end. So occupational therapies are very helpful in helping you to mitigate fatigue. often you need also to have some sort of psychotherapist or mental health help. I'm a big fan of meditation. I think for the right patient, meditation could be a powerful tool to help with anxiety, for example, to help with sleep. So usually the care of MS requires more than just one provider.
So from Pam, with the new FDA concerns with MRI contrast, how else can inflammation be diagnosed?
Yeah, and we talked last week about the concerns on gadolinium and how in certain patients, particularly in those with impaired renal function, the contrast can accumulate in certain tissues, leading to complications. And that's why, unless you absolutely have to do contrast enhancement for a surveillance MRI in someone that is clinically stable, I don't do MRI with contrast because it's not necessary. So when someone has already established MRIs in the past, and as long as you don't change MRI scanners, as long as you go to the same scan every time, then you can look at change by just simply counting lesions. And the situation that could occur is that if you change MRI scanners, if you go from a 1.5 Tesla, for example, to a 3 Tesla, that new MRI may show more lesions, not because you have no lesions, but it's because the scan strength of the field is higher. So that's why I always recommend stay with the same scanner. And if you don't want to have contrast, that's fine. We will just simply look at a number of lesions and count those. So that will be a way to, in a sense, assess the presence of new lesions without doing contrast enhancement.
Thank you. So from Amy, she says, hello, Dr. Miravalle. I was one of your patients in Denver, and I miss you dearly. I hope you are enjoying Fort Collins. What kind of impact may I experience with perimenopause/menopause and MS?
All right, Amy. Well, nice talking to you again, I guess. So we know that there is a big impact on hormones and the immune system. And one of the most perhaps concrete examples of that is pregnancy, right? So when the estrogen levels go up during pregnancy, we see that there is an anti-inflammatory effect, and that's why most individuals, most female pregnant with multiple sclerosis, they remain clinically stable. And after delivery, when estrogen levels go down and progesterone levels go up, that's when you see that there is a risk of relapse. In menopause, even though there may be a similar effect in hormones, is not as abrupt as you see in pregnancy. It's more of a chronic effect. And usually that change in hormones is not going to impact the inflammatory portion of the disease, but it may impact some of the symptoms. And we see that, individuals, for example, that are going through menopause with hot flashes and the changes in body temperature, they might experience more fatigue. And we know that, increased body temperatures are not good for MS. Patients don't feel good when body temperature goes up. So we may see some fluctuations in levels of fatigue. We may see some also fluctuations in mood and behavior. Anxiety, depression could be something that may become more evident. So it's always good to talk about that with your provider. And the other issue that is frequently seen in this period is sleep distortion. And sleep is something that we rarely talk about in MS and is a very important topic, particularly in someone that has chronic fatigue and nothing seems to help. I always recommend to do a sleep study because you will learn a lot about perhaps sleep interruptions and issues with sleep that perhaps once we start affecting that, your energy level will increase during the day. So those are the type of changes that could happen during menopause.
From Lisa, in your initial slide, you explained that a high level of inflammation seems to trigger a MS. the inflammation in the diagram, however, sloped downward. So if inflammation fuels the disease, could you please clarify what you believe is the reason for MS persisting when inflammation decreases?
Yeah, and that's why the second phase of MS, the degeneration, is the one that increases over time, right? So going back to that slide, let me see if I can actually move the slides quickly. So when inflammation goes down, degeneration goes up, and that's why individuals with MS worsen over time. Oops, I think I went too far. Here you go. So it's true, inflammation goes down, but then degeneration goes up, and that's the reason why MS continues to progress over time. We are still debating, and when I say we, is the scientific community in MS, whether inflammation and degeneration are two different processes or one drives the other one. The truth is that the more inflammation someone had early on, the more likely that they will have progression in the future. And that's why it's important to stop inflammation as early as possible.
Interesting. So what are some ways to keep the brain reserve up and well?
Marcelo, so I love the question. The brain is one of the few organs that the more you use it, the better it gets. So hopefully after these last 2 weeks, you got the message that whether it's through physical activity, whether it's through cognitive activities or both, the more you use your brain, the more you can improve that function. And that's something that is not just an opinion. So when you look at, for example, the use of functional MRIs in individuals that are trained in certain function versus individuals that are new to the function, whether it's a motor skill or a cognitive skill, the more you repeat that function, the more you learn how to do that, the more efficient the brain becomes. So that's why we are talking about this. We are talking about the importance of training with physical therapists, right? Training with occupational therapists, being able to not only use your brain more, but use your brain in the right way.
And from WG, do different facilities give different MRI results? So are all of the MRI machines the same?
So an MRI machine, no, they're not the same. So they're different brands, they're different field strengths, as we mentioned before. The most popular ones are 1.5 Tesla and 3 Tesla. The higher the number, the more sensitive they are to identify lesions. But the result itself, the interpretation of the MRI, it will be something that depends on the radiologist that reads the MRI. Most MS specialists, we will read the report, but also we will look at the MRIs ourselves, and we will make our own interpretation of the MRIs. And the reason being is because we are also trained on MRIs in MS, which is more specialized than just simply a training on MRIs. So if you're having your care in an MS center, very likely your doctors are looking at the MRIs themselves. I always like to do that in front of my patients. So at the same time, I can educate the patients on what is happening. I think when patients understand what we're looking at MRIs, they become more knowledgeable on not only the reasons why we do MRIs, but also in their disease itself. So I think it's important to look at your own MRIs with your doctor and understand why we do that.
So this is a COVID-19 question from Alessandra. Why is it that COVID-19 is so dangerous when having an MRI scan? So her reasoning is many MS centers throughout the world have stopped doing MRI scans for MS because of COVID.
No, I think it has to do more of a practical reason to try to prevent patients from coming to a healthcare facility in the context of a pandemic. So I think, assuming that most, if not all, patients with MS will be immune compromised because of the medications we use. We try to prevent patients having to come to a hospital or a healthcare facility and being exposed to other patients that perhaps have COVID-19. So the MRI itself, it's not going to increase the risk of infection. It's just where the MRIs are located and the facilities are actually areas that are of high risk. And that's why most centers, including ourselves, we moved to telehealth to try to prevent patients from coming to clinics or hospitals unless it's absolutely necessary.
Great. And then this one has to do with diet from Maria. Can we reserve or can we improve inflammation through diet and healthy food?
Yeah, so we touched on that last week a little bit. There is a whole area of research called the microbiome. And that's something that if you're not familiar with, Maria, I recommend you perhaps read about it, which has to do with the relationship between bacteria in your gut and inflammation. And that usually has to do with local inflammation in the gut or systemic inflammation. May or may not be related necessarily to the type of inflammation we see in MS. Though when you start looking at recent research in MS and microbiome, there is a relationship between certain bacteria in the gut and how that influences, for example, relapses, how that influences, for example, inflammation in MS patients. So there may be a relationship between the two. And yes, you can affect inflammation through diet. Pretty much everything we eat is going to influence not only the microbiome, but also it could influence inflammation. As I mentioned before, the diets that appears to have more of the anti-inflammatory effect in MS is what we call the Mediterranean diet. And those are diets that are high in grains, high in terms of animal products, fish, for example, diets that are actually high in antioxidants, and diets that perhaps are low in trans fats or saturated fats, for example, the ones that are solid at room temperature. So that's the Mediterranean diet is perhaps the one that has the most evidence or data in MS. And then you have different type of diets, the paleo diet, the WALS, the gluten-free, the SWANG diet. So each of them have different principles behind. They do share common areas, which is this concept of grains and vegetables and fruit and fish. They seem to be beneficial for MS in terms of fats, the ones that are liquid at room temperature, the monounsaturated fats, the polyunsaturated fats appears to be healthier for MS than those that are solid at room temperature, like the trans fats or the saturated fats. So that's usually kind of like the summarizing the very complex, actually, area of diet in MS.
And we are at the top of the hour. There's one last question I really want to ask you, though, from Lisa. Can you please clarify what is entailed in cognitive behavioral therapy as it is applied to MS?
Yeah, so cognitive behavioral therapy, if I can explain it in very simple terms, is the use of cognitive training to influence behavior. So if I can actually become a nerdy neurologist for a second and explain how the brain is organized from an anatomical standpoint, you have two types of brain. You have the cortex of the outer part of the brain, the cortical part of the brain, the one that you can think, you can control, you can voluntarily influence. And then you have the limbic part of the brain, the deep part of the brain. Those are your emotions, your anger, your hunger, depression, anxiety, sleep, dreams. So that's what we call the limbic system. That's a deep part of the brain. So what cognitive behavioral therapy is doing is trying to align the two. So using the cognitive brain, the one that you can control, in order to influence your involuntary limbic brain. So cognitive behavioral therapies are very helpful, for example, to treat anxiety syndromes, for example, insomnia, fatigue. So it's a big area of medicine that I always recommend because it's a way. It usually takes longer, right? So that's why sometimes patients don't like it because it's not going to be immediate. But if you are trained in cognitive behavioral therapies, you can actually, in the long term, get better benefits than some medications that are used to treat some of the symptoms. Usually that's done through an occupational therapist or a neuropsychologist.
Great. So this concludes our two-part webinar series, MS on Your Mind. All of these questions are so fantastic, and I don't want to stop, but I'm pretty sure I'll have a few people angry with me if we continue. So once again, the recordings of both of the webinars will be posted on mymsaa.org within the next few weeks. MSAA would like to thank our funding partners, Biogen and Bristol Myers Squibb, for supporting this series. We would also like to thank Dr. Augusto Miravalle for taking time out of his extremely busy schedule to provide us with this great information, and of course our great friends from Impact Education for their partnership in delivering tonight's program. And again, we would greatly appreciate it if you complete a brief survey that will immediately follow this slide. It's only about 5 questions, and it really helps us direct resources to the appropriate areas of need. So on behalf of MSAA, thank you so much for spending your evening with us, and please enjoy the rest of your week.